Assalamu alaikum. How are you everyone? I hope all are fine. Today our lecture about medication management in Ramadan according to evidence-based strategy for safe fasting. Ramadan is a month full of mercy, blessing and meaning. Before we start, let me introduce myself. My name is Ahmed Sabri. I have graduated from Faculty of Pharmacy 2005. Then I have traveled to Saudi Arabia 2007 till 2013. Worked there as community pharmacist. Then I have returned back to Egypt for 3 years. Then again I have traveled to United Arab Emirates since 2016. I have worked in Qasim Women and Children Hospital since 2017 till now. I have got an American Board of Pharmacotherapy on December 2023 and Alhamdulillah I have got MOH Pharmacotherapy Specialist degree on January 2026. I am working as inpatient clinical pharmacotherapy specialist. I have participated in some projects with Ministry of Health, which now some of these projects covered by EHS, like anticoagulant management protocol to be, inshallah, published all over UAE. Also, I have some projects in my hospital, like leading a team to publish or establish a reference for extemporaneous compound, and some protocols for electrolyte management in critical care like NICU and PICU. I welcome all of you, and let's start. Bismillah ar-Rahman ar-Rahim. First, we need to know what Ramadan for Muslims. Ramadan, it's a ninth month of the year. It's a month of fasting, worship, discipline, and mercy, in which Muslims seek spiritual growth while preserving their health and well-being. So, we have a critical rule in this, because fasting with medication and chronic medication and with chronic illness and some medication has some challenges. So we need to know what is the challenge in Ramadan. First, fasting duration means stop eating, drinking for approximately 12 to 16 hours depending on location. Also, all over the world, nearly 2 billion Muslims will practice fasting. So, which means that wherever your position in the healthcare system all over the world, surely you will meet some of those Muslims who have chronic illness and take chronic medication and practice fasting. So your rule to adjust their medication to protect them from any change, because what we will take later, we will know what is a change can be. From any change can affect their illness or affect the effectiveness of their medication. Also, many patients, despite their chronic illness, they insist to fast. So your rule have to help them to keep their health well. Some of patients should be exempted from fasting. We will take a general idea now, and later on we will take it in details. Like the patient who have chronic disease, severe or unstable, like diabetes, hypertension, hypertensive, chronic kidney disease, psychiatric, like this, acute illness, not chronic but acute, frail elderly, the older adults who have reduced physical strength, long, they have long time without movement, low physiological reserve, and they have increased vulnerability to illness or stress, pregnancy or breastfeeding, which they have complication, and the travelers, and some other based on religious ruling and medical advice. And although all of these points, most of the patients insist to practice fasting. So our role as a clinician, try to make the balance between safety and respect their religious commitments, and also to prevent the complication. These complications can come from the decrease or from the over therapeutic effect of the medication or under therapeutic effect of the medication because of fasting, and the physiological change happens inside the body from the fasting. This we will discuss later. Also, we need before Ramadan, we need some consultation essential, some laboratory need to be done to confirm that their health and they are able to fast. Medication planning, to be honest, should begin before Ramadan, minimum 2 to 6 weeks before it. After this lecture, we will be able to identify patients who shouldn't fast without any excuse. We need to convince them that fasting will harm their health, and also this is not allowed by Islam, because Islam protect the soul, and he protects the human from harming himself. And if fasting will harm the people, will harm the Muslim, so we need to clarify for him this fasting is forbidden for him. Apply risk stratification principles, and also adjust medication by pharmacologic class. List clinical red flags requiring fast breaking. When the patient insists to fast and something happened, what is the conditions which happened during the fasting? If I notice, I need to tell the patient immediately, you have to stop, you have to break your fasting. Counsel patient effectively. What is the foundation of fasting? Clinical foundation of fasting. We need to know what is the changes happen inside the body while fasting. Some physiological change going on while fasting, like metabolic changes. Our glycogen will be depletion, decrease, increased lipolysis, reduced insulin level. Also, fluid balance will happen. So I have high risk of dehydration, and this will affect some effectiveness of some medication and increase the adverse effect of other medication. Increase the risk in elderly and diuretics. The dehydration will increase, this increased risk in the elderly people and the people who's taking diuretics, either loop diuretics or thiazide diuretics. Electrolyte consideration. Also, there is hypotension risk and volume depletion because of some electrolyte imbalance. Okay, pharmacokinetic consideration. We know, of course, that we have studied before the difference between pharmacodynamic and pharmacokinetic, and we said we know that pharmacokinetic means the effect of the body on the medication, but pharmacodynamic means the effect of the medication on the body. So fasting affects mainly the pharmacokinetic more than pharmacodynamic, because when the body have some physiological change, so this change will affect the medication. So the body, changing body will change the effect of the body on the medication, which means pharmacokinetic. What these kind of changes in the pharmacokinetic can happen to the medication during fasting. First, when I talk medication, there is a trip or like a journey of the medication once I took it till I excrete it. First, when I take this medication, the first process happen to the medication absorption. I will eat it, okay, drink it by oral, for example, so it will be digested if it is oral route. Then the absorption will be affected because the pH and the gastric emptying rate will be affected by the fasting. So the medication also affected by food, like food dependent medication will be affected. After absorption, the medication need to be distributed through the bloodstream all over the body. So changes in hydration also affect the drug level during this circulation. And the circulation itself will be affected, which means the journey or the travel of the medication throughout the body will be affected. Also metabolism. In metabolism, we have something called circadian rhythm. Circadian rhythm means what? We know all that we have something called biological clock. Each one of us has his own biological clock, which means that the body has like sleep pattern. If your sleep pattern changes, your biological clock will be changed. And if biological clock changes, the circadian rhythm, which means the metabolism of the medication, will be also changed, okay, according to day-night cycle. For example, if in normal days, except Ramadan, most of the people are sleeping at night, should sleep at night and wake up at morning for their job. So in this case, this is a normal biological clock, which keep your health in a proper way or a proper level. But when you change this biological clock, especially in Ramadan, so this happen the affect this it will affect also the metabolism rate, the elimination, because I have low perfusion to the kidney. So of course the renal excretion of the medication will be changed. Okay, so also I have some medication which we will discuss later excreted by kidney. So if any change in the renal excretion rate of the medication of this medication, it can cause that their therapeutic effect will be more. So it will be over therapeutic effect, which can cause toxicity. Okay, I have four major risks in as a clinical condition in Ramadan. I need to focus on these. Of course, there is others, but I pick up these four because it's the most important. That all patients who practice fasting and they have some abnormal condition, they have four risks: either hypoglycemia or hyperglycemia or dehydration or thrombosis. Okay, now if we want to classify the patient according to risk stratification to know whose patient are high risk, who's moderate risk, who low risk, whose patient I need to monitor regularly, and whose patient I need to give only some advice, and whose others is not important to monitor. According to what? According to their condition before Ramadan. So the high risk people, I need to advise them against fasting if their condition is unstable, like the patient who has unstable diabetes, his either fasting blood glucose or postprandial or HbA1c are abnormal, recent MI, patient myocardial infarction recently less than 3 months before Ramadan, advanced CKD, this we will take the more details later, severe heart failure, which means that ejection fraction less than sometimes 40 or 35 or 30, uncontrolled epilepsy, or this patient I need to focus with them more. Moderate risk, controlled diabetes, but he has multiple medication, antidiabetic, CKD stage 3 specifically, elderly on polypharmacy, which means that old people are taking many medication. The low risk people who is stable chronic condition and he's taking once daily medications. This is also another slide to classify and give us more details about this kind of risk stratification. The patient who has unstable diabetes, like severe hypoglycemia, less than incidence of severe hypoglycemia less than 3 months, or DKA, diabetic ketoacidosis incidence happened less than 3 months, or poor control diabetes, which patient taking medication but always he has abnormal reading of blood glucose, recent major cardiovascular event like MI, stroke, hospitalization for heart failure, advanced CKD means stage 4 and 5. We said that stage 3 from the moderate risk, or patient on dialysis, severe heart failure, according to classification of New York Heart Association 3 to 5, or decompensated heart failure. This is a critical case of heart failure, need the patient to be hospitalized. Uncontrolled epilepsy, like recent seizures, or patient on multiple anti-epileptic medication. Frail elderly, old people age more than 75 with ill health or functional impairment, pregnancy with diabetes, acute illness at time of Ramadan. These people I need to uh, like advise them not to fast, but if they insist, I need to monitor them closely and give them the advice which we will discuss later. Moderate risk may fast but close medical supervision, like controlled diabetes, as we said, on multiple medication, either basal insulin or oral agent, CKD stage 3, stable with monitoring, elderly on polypharmacy, and stable cardiovascular disease, no recent event, controlled epilepsy on once or twice only antiepileptic, low risk, as we said before. Okay, before Ramadan, I said that the plan should be monitored 2 to 6 weeks before Ramadan. What is the key assessment? What is the lab, or what is the monitoring parameters I need to advise the patient to do before Ramadan? First of course, the HbA1c for diabetic patient, renal function, EGFR, because drug excretion and hydration risk, blood pressure control, and this blood pressure should be monitored closely also during the months, home monitoring capability, medication review to check the time and dosing to be adjusted, and also if any history of hypoglycemia or any episodes from like stroke or cardiovascular events or whatever. Adjustment principles. Principle 1. I have some principles in adjusting medication. I need you to understand these principles because we are, as a pharmacist, we are not stick with like solid information without any flexibility. If we realize the principles properly, I can giving a proper advice, because you know when we studying in our college the materials, we studied the like the medication, either pharmacology, clinical pharmacology, clinical pharmacy. We studied this as a medication, but we are while we are practicing this, we practice this in the fact in the real world. We treating patient. So each patient has its own story. I can't generalize all my information to all patients because it's not a machine. It is not a solid information. I need to be flexible from patient to patient according to their condition, their own condition. So it's very important to understand well these principles. Principle one, timing is everything. If patients are taking medication, PID for example, 2 times a daily, I have 2 times also in Ramadan, which iftar and suhoor. So I need to like shift the time before Ramadan to the time suitable to the or according to the time availability in Ramadan. Also, if there is a chance to shift medication to once daily or long acting to decrease the interval, decrease the frequency, it will be perfect. Principle 3, what is the high risk medication? I need to focus. Principle 4, monitoring doesn't break fast. Monitoring doesn't break the fast. Some patients have some beliefs if they making like blood glucose test or some test, it will his fasting will be break. This is I need to clarify this point for them. Principle 5, I know the threshold when I need to break the fast.